from Amman, Jordan, at the Farah campus. And the topic for tonight is the butterfly glioma. And the backdrop is that pictures from Jurassium, which is the only complete Roman era town preserved, the only preserved city outside Rome. So, butterfly glioma. The definition is a glioma which has an image of invading the rostrum, the genu, the body, and the splenium of the corpus callosum. Corpus callosum is a midline structure. If the tumor is involving the parts of the corpus callosum going both sides, it's called butterfly. Butterfly بالعربي يعني فراش, زي الفراش. It is the most aggressive form of JBM. Glioblastoma multiforme is very malignant. This is the most aggressive malignant type. The reason is corpus callosum is made of tight fibers and it is resistant for invasion. So if it is invaded, this means that this tumor is very nasty. Like this, tumor is involving the corpus callosum and involve the anterior part of the corpus callosum called the genu. Could be small, it could be large. Could be involving the central part of the corpus callosum called the body of corpus callosum. It could be taking the posterior part of the corpus callosum, which is called the splenium of the corpus callosum. And these are by cases of glioblastoma multiforme, again representing the facts which I mentioned. So it could involve any part of the corpus callosum. These are my cases. They're really aggressive. This is involving the splenium of the corpus callosum, which is the posterior part of the corpus callosum. So what is corpus callosum? If we look at the interconnecting fibers, which is white matter, there are various types. Association fibers, commissural fibers, or projection fibers. Association fibers means fibers within the same hemisphere, right or left. Commissural fibers between right and left. Projection fibers between the brain and the spinal cord and the brainstem. So, corpus callosum is one of the commissural fibers. Association fibers, as I said, within the same hemisphere. So, within the right hemisphere or within the left hemisphere, various types. The uncinate, the inferior fronto-occipital, the uncinate, the superior frontal, and so on and so forth. So either they are long, connecting, say, frontal lobe with the occipital lobe, or they are short, connecting with the same lobe. But the commissural fibers are connecting right and left, left and right. And the three main types of this are the corpus callosum, the anterior commissure, and posterior commissure. Corpus callosum is a midline structure connecting right and left, like this. Fibers goes from one area to the other. Mirror image. So superior frontal gyrus, middle frontal gyrus to middle frontal gyrus, occipital to occipital. Because this is a small or short, it's called forceps minor. This is long, it's called forceps major. So you can see this connecting right and left. And that's why we are, when I talk, my hands move, because there is an association between the right and left. If I don't have this, then my right hand would move and the other one does not know what's going on. So this is the corpus callosum connecting left and right, like that. So this is the corpus callosum. It's made of rostrum, genu, body. There's a narrowing here called isthmus and the splenium, anterior and posterior. So it looks like that. And even that, we can divide it into areas. And the rostrum, the genu is made of two parts, superior and inferior. and then we have the posterior geno, and then we have the middle body, anterior and posterior, the isthmus and the splenium. So a neurosurgeon should be aware of this. And I tell you, if I ask this question in the board exam, no one will answer it because no one knows anything about it. As if asking about the brain is a crime. So, anterior, posterior, this is the corpus callosum, the geno and the splenium, and above it immediately is something called cingulate gyrus. Why am I mentioning this? Because it has very much to do with the surgery that we're going to talk about. It's called cingulate gyrus or cingulum. So this is the corpus callosum. Immediately above it is the cingulum, and it connects anterior, superior, etc. So it connects to the superior frontal gyrus, it connects to the cuneus, the precuneus, it connects down here, and it connects backwards here. So this is the manifestation. This is the corpus callosum. The cingulate gyrus is made of the dorsal part and the ventral part. And it connects, as I said, with various connections. Here, posteriorly at the splenium, it connects with the precuneus and the cuneus, which is the occipital area. So we are talking about brain networks. These are networks that are related to certain activities, including just listening. So if I'm talking, I'm doing a certain task, which is talking. And also, I'm moving my right hand. So I'm doing two tasks, talking and moving my right hand. This is a specific task. This is motor, and this is speech area. If I'm at rest, we still are working. There is a network which controls you when you are just resting, doing nothing. That's why it's called default mode network, because it is resting. And if you do something in particular, like a test, like talking or writing or singing, then it goes to sleep. So it only acts when you are just resting. Default mode network. Default mode network. And it is made of the cingulate gyrus, which I just mentioned, the medial prefrontal cortex, the medial temporal, the precuneus, and the parietal cortex. So it has wide connections. Again, this is corpus callosum, this is cingulate gyrus or cingulum, and it connects to these areas, the DMN. So from the cingulate gyrus, we go into the superior frontal gyrus, we go into the gyrus rectus and orbital gyrus, and we go backwards to the cuneus and so on. So it connects. That's why it is called resting mode. The same thing here. So corpus callosum, very much related to the cingulum. Cingulum is made of two parts, the dorsal part and the ventral part. This is the tractography that shows you this. This is MRI with the tractography that shows you this in particular. This is superior view that you can see. Look at this beautiful picture. This is tractography. The new MRIs can show you this. So, corpus callosum is in blue. It goes around the cingulate gyrus. And people talk about no God. Can't be. It can't be that these fibers are connected by an explosion in the galaxy. There's got to be a creation here. So what are the functions of the default mode network? Very important. As I said, it functions when you are resting. بنحكي بالعربي عماله بيحلم واحد هيك بتطلع فيك ويحلم اسمه day dreaming. بنشوفها في المساعدين في السيرجري بيكون صراحة daydreaming. So daydreaming, planning for the future. شو بكرة بدي أسوي؟ أنا بدي أصير كذا. So you are motivating yourself. So it's most important for motivation. How I would reach my goals. كيف بدي أصير جراح المال كويس. What do I think about myself? أنا كويس ولا مش كويس؟ أنا نشيط ولا كسلان؟ Thinking about others. يقال إنه this default mood network, is the one responsible for discrimination. I'm afraid of the blacks, or the blacks are afraid of the whites, or whatever. So if you damage this, you will affect the person, his motivation and teaching goals, and he will get what we call abulia or akinetic mutism. Somebody who's just sitting there, doing nothing, not moving, does not think, doesn't want to do anything. This is very bad. So let's see about the JBM, which is the butterfly. How do we manage it? This is important, especially in Jordan, especially in the third world countries. Neurosurgeons, and I mean young ones, are taught that you don't need to excise butterfly glioma. You just need to take biopsy. And this is criminology again, like the shunt. You can't do the pineal tumor, you cannot do the craniopharyngioma, you put a shunt, bilateral shunt, so what? And the same thing here, because he does not know what we have said. He does not know the areas of the brain. I tell you, 99% of people who sit for the board exam do not know anything about the brain. They don't know what's the difference between a frontal or parietal lobe. So they are taught that you just take a biopsy and move. Why? Because they are afraid of this. Akinetic mutism, abulia, injury to the head of caudate, injury to the septal nuclei, or injury to the anterior cerebral artery. So what is abulia? It is lack of initiation or will. It's complete apathy. It's called akinetic mutism. Also, it is called ectasia, abasia. Psychologists know very much about this. I don't know whether Dr. Rahan people are here. No. So traditionally, neurosurgeon will go just for biopsy and send him for radiochemotherapy, another crime. There is nothing called biopsy here, except in very rare cases. Biopsy was made to suit those mediocre surgeons who cannot do the surgery. Radiation is made for those mediocre surgeons who cannot do the surgery, and so on. We have to know this, that prognostic factors governing a glioma are related to age. The older the patient, the worse the prognosis, yes. Karnofsky performance scale. The lower the Karnofsky performance scale, the worse the patient. But there is also genetic profile that we will discuss. And this is most important, extent of resection. If you excise much of the tumor, then you give the patient the best chance. If you take biopsy, you have given him no chance whatsoever. And the criminology about it, that people who do these biopsies, they charge the patient the same amount of money that you charge for a cranioplasty. So there are genetic factors, genetic markers, very well known now to us. IDH1, this is bad. If it is there, then the tumor is bad. EGFR, epidermal growth factor. MGMT, if it is there, it's better. FEGF, the vascular endothelial growth factor. PTN, MP9, TP53. These are genetic factors. This is a great man from Turkey, Muhammad Ghazi Yazarjir. He is the man of century of neurosurgery. I know him very well. And he visited Jordan several times. This is with my wife, and this is with his wife. And he is one of the most celebrated neurosurgeons around the world. Long time ago in the 70s, he believed in radical excision of a tumor, glioma or no glioma, radical excision because you will benefit the patient. If you don't know anatomy, if you don't know surgery, if you don't have a good teacher, then you will remain small. This man made the neurosurgery great, and we are great because of him. Let's look at the papers. This is Raymond Samaya from the States, a friend of mine. He's a good oncologist. What does he say about? He says, limitations of a stereotactic biopsy. Don't do stereotactic biopsy. And he shows you this. This is the tumor, and this is the surgery. So I'm not talking, as Ibrahim said, I'm talking about evidence-based medicine, papers that are published there. Still, there are mediocre surgeons who could sit there and say, we will do it just biopsy because you have to be safe with the patient. No, you want to be safe with yourself, which is a crime. Another paper, Assessment of Outcomes, 2012. 12 biopsies, 11 craniotomy. Survival here after biopsy is 48 days. Survival here is 265 days. So this is evidence. Craniotomy is much better than biopsy. Giovanni Brugi, again another friend of Jordan, Italian, very clever man, oncologist, 2013. This is the statement. In a dedicated brain cancer surgery center, the maximal safe resection of all the tumors is the standard of care. What is the standard of care in Jordan? Biopsy. And nobody cares. And nobody raise a voice or raise a finger. I will raise my finger until I die, until we expose this mediocre surgery and surgeons. 2014, another paper. There's a plotting here. This is biopsy, they live short, and this is craniotomy, they live better. 48 patients, they were associated with a longer period of time. Mind you, the glioblastoma is a bad disease, so the more days and months you give to the patient, the better. Raymond Sawaya again, 2015. Look what he's saying. Can we do better than gross total? نعمل أكثر من gross total. مش biopsy radical excision بدنا أكثر. And how he would do that? By removal of additional portion of the flare abnormality. He doesn't go for the contrast, he goes even for the traces of the tumor on the flare, which means that he's doing extra. And he says this will give patient more time to live. Michael Shigru, 2017, looked at this default mode network. Look at this. This is the Corpus Callosum. This is the gyrus. This is the Cingulate Gyrus. And this is the singular bundles in it. This is the ventricle. This is the head of the caudate. And these are the septal nuclei. If you know this anatomy, then you can remove the Corpus Callosum tumors without causing abulia and akinetic kinetism. If you don't, and 99% don't, they will go for biopsy. And they would stand there talking. So this is the corpus callosum, and it is surrounding the cingulum. So if you go here to this area, you will damage this, and you will cause abulia. If you know your anatomy, once you reach there, you make a turn and then go for the tumor, like this. This is the cingulum. How many neurosurgeons in Jordan know where is the cingulum, or what is the cingulum? 2018, Mitch Berger. Mitch Berger is the man of glioma in the world. And he published lots of papers. His main work is about gliomas. And look at this. The biopsy and the craniotomy. Overall survival, survival-free. It is well documented. Yet somebody would stand and say a biopsy. Oboku, again, this is recent, 2018. There is a major benefit of resection versus biopsy. 9 excision, 12 biopsy, different survival time. This is evidence-based medicine. Khalas, finished. So let's present our cases. 2 cases to be presented. We'll go through them quickly. This man is from Iraq, 59-year-old, male, Iraq. He's a doctor, by the way, by profession. I will go through very quickly. This is him, his eye movements are okay. So he did not have major things except that his legs were a little bit wobbly and he had some headaches. But look at this, his urea was elevated, his sodium was 120, dangerously low, dangerously low. Sugar is elevated. And these are his MRIs, a butterfly glioma. But it is not equally distributed. You can say that the right side is more than the left side, which is quite often. You can have the same tumor on both sides. You can have one side more than the other. Still, it is called butterfly glioma. So here you are in various sequences. And the corona. Syndrome is here. You damage it, you cause problems. So it is a huge tumor. What is the biopsy going to do? Nothing. Even if you give radiotherapy and chemotherapy, it's useless. Absolute useless, utter useless, because there's a huge volume of the tumor. And anybody with just 1-2 neurons functioning will tell you that the effect of radiation and chemotherapy is dependent about the volume of the tumor left. Leave a huge amount of the tumor, radiotherapy and chemotherapy will be useless. So it's a game, it's a mockery, it's a crime. What is the differential diagnosis of this lesion that we have seen? Very funny. Demyelinating disease. MS loves this corpus callosum, and they present like a tumor. This was by mistake. This is a published paper, was taken to theater, and the histology showed demyelinating disease. Another demyelinating disease proven by histology, lipoma of the corpus callosum. Another disease where there is a lipid deposition in the corpus callosum. So we did a few consultations. Dr. Nassim is not here as a cardiologist. This is the man, the Iraqi man, as we said. He says cardiology is okay, basically. Dr. Maurice, again, he's not here. Patient has glioma, put him on Kibra, 500 milligrams, etc. Dr. Malik Ayad is urology because we said the sodium is low, and he found that there is residual volume of urine in his bladder, which he attributed to the enlargement of the prostate. Dr. Khalid Al-Assad as pulmonologist. So it is the global care of the patient. We don't care about how much time and effort that is needed. You need to be absolutely safe. Again, back to the package, which is another crime in medicine. If you take a patient as a package, you will not do anything with this because you want to save as much money as you can save. Dr. Muhammad Juma, would you like to make comments? Please.
Thank you, Dr. Ibrahim. Well, regarding, I will talk a few words about hyponatremia. First of all, we have to look about history if the patient is taking diuretic or not. It is very important. If there is no diuretics in the history, you have to look for hypothyroidism and for adrenal insufficiency to exclude these two entities. If both entities are excluded, we must think about inappropriate ADH syndrome secretion. In such cases, as far as sodium is 120, it is the best approach in his case is water fluid restriction plus hypertonic saline, at least to elevate sodium above 130, which is safe. This is actually, I think, what we did. You have to correct, of course, sodium over at least 24 to 48 hours, not immediately to raise sodium from 120 to 140 because you can cause more damage. This is regarding hyponatremia. Regarding his diabetes, already we discussed the best approach, particularly patients on high-dose steroids, is to put them on basal bolus insulin. Usually we calculate the dose according to body weight, and it is usually we start with at least 1 minute per kg, divided into basal 50% and bolus redosages 50%. And we do usually frequent glucose monitoring to adjust the dose immediately, day by day and hour by hour. Thank you.
Assalamu alaikum. Good evening, everybody. My name is Firas Abu Hashim. I'm a sociologist at Farah Medical Campus. During this, the management of and anesthetizing this patient, the most important, there are two important factors regarding this patient. Two entities were very alarming in this case. One was the very high blood sugar, which the patient did not have any previous recollection of his condition. And the other one is the severe hyponatremia that he had. So I'll be talking very briefly, just to reiterate what Dr. Muhammad Juma has mentioned, and why hyponatremia per se is extremely important to the patients, to the management of the patients, and to my fellow colleagues, the anesthesiologists. So disorders of the sodium balance occur in up to 30% of hospitalized patients, which is severely correlated with increased mortality and morbidity in these patients. And in sodium homeostasis, just very briefly as an introduction, the normal level is 134 to 146 millimole per liter. And the sodium is a major determinant of the serum osmolality, normally between 280 and 295 milliosmol per liter. Just briefly about the sodium regulation and how our body handles the sodium. So if there is a decreased sodium concentration, the renin-angiotensin aldosterone pathway is activated just to raise the body sodium to normal. And if the sodium concentration is elevated, the osmoreceptors in the hypothalamus senses that and then activate the antidiuretic hormone. In addition to that, the atrial natriuretic peptide plays a very important role in excreting sodium and regulating the sodium levels back to normal. What about the classifications? Many classifications have been mentioned in the books. It goes, it's a spectrum from mild to severe disease. But severe disease is when we have sodium levels below 125 millimole per liter. Briefly again about the etiology of hyponatremia is divided into three major classes. The first one is gaining water in isolation. And this is very important because mostly it's iatrogenic, especially when we use dextrose solutions. And when we have patients with syndrome with inappropriate ADH secretion. And the second class is gaining water to a greater extent more than gaining sodium. This is very important in patients with liver failure and congestive cardiac failure. The third class is sodium depletion to a greater extent than that of water, which can be divided further into renal and non-renal causes. The renal, most importantly, especially related to neurosurgical disorders, the cerebral salt wasting syndrome, which is mostly associated with traumatic brain injury and brain tumors, and the non-renal, which many causes can cause that. So regarding our case, what about hyponatremia and tumor-related conditions? About 14% of hyponatremic patients, inpatient population, is due to underlying tumor-related conditions. The mechanism behind that has been divided into four major classes, 1A through 2B. First is the excess of ADH hormone, and then the excess intake of free water, renal solute conservation, and renal solute loss. What about symptoms and signs of hyponatremia? The symptoms and signs associated with hyponatremia are related to two major categories: the degree of the imbalance, and then the speed at which the imbalance have occurred. So time is an essence with the signs and symptoms and severity of the signs and symptoms in these patients. Slowly evolving hyponatremia is frequently asymptomatic. This is as opposed to acute hyponatremia. Patients in whom acute severe hyponatremia has developed in under 48 hours can present with very alarming signs and symptoms such as coma and convulsions. Additionally, they are at risk of death as a result of cerebral herniation. This is due to brain edema. And certain groups are very much at risk, higher risk than other populations, such as children, hypoxic patients, premenopausal women, are all at increased risk of developing cerebral edema. Very briefly, as Dr. Muhammad Juma has mentioned, in terms of management, now the current guidelines recommend 46 millimole per liter increase in sodium level should be done within 24 hours, and 12 to 14 millimole per liter as a maximum in 48 hours, or 14 to 16 millimole per liter in 72 hours. So rapid correction is an absolute contraindication in these patients. And in moderate to severe cases, this requires blood sampling every 1 to 2 hours, and these patients should be taken care of in the intensive care unit. Now, 0.9% saline is the mainstay of treatment. The reason I mentioned 0.9% saline, because usually people call it normal saline, and it's absolutely not normal. So normal saline, by evidence-based medicine, is absolutely not normal, because the concentration of sodium is 150 mole per liter. And then it might cause severe hyperchloremic metabolic acidosis according to the Stewart theory. So Hartmann solutions can be used in cases of hyperchloremia instead of 0.9% normal saline. So 3% normal saline, 3% saline should be reserved for those patients with severe neurological compromise, such as in cases of seizures and coma. The major risk associated with excessively rapid sodium correction is what is called osmotic demyelination, especially point-time osmotic demyelination. And certain patient groups which we should be aware of when we are correcting the sodium levels are more prone than other patients to osmotic demyelination. These patients are the malnourished patients, alcoholics, and burns patients, and those patients with severe hypokalemia. So just a few take-home messages. Hyponatremia is the most commonly encountered electrolyte disturbance encountered in inpatient population. And the diagnosis may be incidental, such as preoperative evaluation. That's exactly what happened with this patient. And endocrinologists should be consulted to guide the investigation and the management. And acute hyponatremia can cause severe cerebral edema, coma and seizures, and brain herniation. And over rapid correction of hyponatremia would risk the patients to myelinolysis, and the sodium should be carefully controlled with no more than 4 to 6 millimole per liter per 24 hours. And thank you very much.
Yes. It's very important when you see patient with hyponatremia as a lab director, you have to know when the test was done after it was withdrawn from the patient blood. Because as a lab director, we sometimes encounter that the electrophoresis or sodium balance is out of order, so we have to send it to another lab. And if you have more than 1 hour delay, you will get hyponatremia artificially. So be careful. When you take some blood, you have to make sure that there is no delay in performing the sodium test, because if you separate the blood and you can sit more than 1 hour, you get hyponatremia in all cases. So because the consequences of correcting it is bad, when the patient is really not hyponatremic but falsely hyponatremic, make sure that everything went okay all the way.
Thank you.
Another thing, Dr. Awais stressed that a lot of patients actually with heart failure who are on diuretics, because it is a chronic hyponatremia. Even a lot of patients you can see with sodium 110, and they are free without any symptoms, because it is a chronic hyponatremia due to chronic use of diuretics. Therefore, the symptoms usually occur if it is acute drop in sodium, then you feel a lot of symptoms.
Again, I have to mention that sodium was 110 or 115 can cause death. Sodium 170 can cause death. And if I looked into the practice of surgery on the pituitary gland or on craniopharyngiomas, because they are near the hypothalamus, the surgeon usually goes for a shunt, but if he is clever enough, he may go for surgery, and surgery ends at the end of the surgery, and nobody cares about sodium. That's why 99% of craniopharyngioma surgery in death is due to hyponatremia. So we took this patient theater and we use navigation because we are dealing with very important structures. Me, animal navigation, we use this machine and we make. Basically, if somebody doesn't know about navigation, we make something called navigation MRI before surgery. And this navigation MRI comes on a CD, and the CD puts into the machine, and then we confirm the points that if I put my pointer here, I will see it here on the head of the patient. So we do 100% matching to make sure, and we do this kind of map to make sure that that is corresponding. And look at this, that during surgery, I know where exactly I am. I want to avoid this. I want to avoid the cingulum, right? I can do this with general anesthesia. I can do it with awake anesthesia, awake surgery. Awake surgery has its own limitations and dangers. I don't like it. I use it under GA. I know exactly where I am. I know my anatomy. So I know this point, I'm here, and so on. So that is very helpful in this kind of surgery. At the end of the day, if my imagination is different from the machine, I take my imagination and I forget about the machine. So let's look at the surgery.
The machine is a probe. The navigator is a probe.
It's a probe, but it's a machine where you have put the MRI that you have done before into the machine. So the machine has the MRI of the patient. And then you take these markers and put them into the machine, so the machine will correlate both. And then you make, okay, now let's make sure. This is the tip of the nose, this is the ear, this is midline. So you make sure that you are on the right track. If there is measurement difference, you ignore it.
I hope one day you can explain it with more photos.
Sure, I will. Next case. So this is the surgery. As you know that the tumor is more on one side, so we'll go on one side. If it is bilaterally distributed equally, then we'll go both sides. You can see the brain edema here. The brain is bulging because severe edema is there. And we can immediately look at this color, yellowish color, different from the color of the brain. I know that this is a tumor because I know the consistency of the brain. I know how the sucker feels on the brain, how sucker feels on the tumor. Here we're sending good samples for frozen section. I don't use any sample with diathermy on it because that would mislead the histopathologist. And I know of neurosurgeons who intentionally put the diathermy on the pieces because he was not where the tumor is. So he just want to confuse the histopathologist. Again, you can see the difference. We know where we are. This is midline. And here some CSF is coming out. So I'm approaching to the ventricle. I have to have this 3D anatomy knowledge to go there. Otherwise, I don't. So this is all tumor. And we have to remove as much as we can because we want to send this patient for radiotherapy or chemotherapy. Then a small amount of the tumor is left. And radiotherapy and chemotherapy will be successful. Look at this necrotic tumor. So by the naked eye, you can tell that this is a tumor. And I want to go into the ventricle. Now I am in the ventricle. I should know that the caudate nucleus is here. This is the head of the nucleus here. And here is medially. So this is here. I'm approaching the cingulum. I have to be careful. So I know where the frontal horn of the ventricle. I go around it. The idea is to remove the tumor without affecting any of these areas that we have mentioned, the default mode networks. Still tumor. What would the biopsy do? It will do nothing. It's good for the money in the pocket of the surgeon, a forced surgeon, a mediocre surgeon, who would put the same amount of money in taking biopsy as you put on the, this is the head of caudate, and you can tell the color. Head of caudate is different from the ependyma of the ventricle. So you know you want to preserve the caudate nucleus, you preserve the cingulum, and you have removed as much as you could of the tumor. So glioma or no glioma, biopsy is forbidden. You should go for radical excision of the patient. Biopsy was made by a mediocre surgeon. Okay, histopathology.
This case was sent for section, and we had.
I have put this. Look at this. 3 by 3 by 3 centimeter, 3 by 3 by 2 blood clot with the tumor. In the frozen section, it is 0.3 millimeter. Useless.
You can see the tumor actually was, most of the tumor, 95% was necrotic tumor. And necrosis is really bad in tumor pathology. And once you see necrosis, you know that you have bad tumor. It's a sign of glioblastoma. There was some foci that have viable tumor. So it is very cellular. I can see the tumor is very, very cellular. All these dots are cells and indicating there are cells, and there's vascular proliferation, the tumor. You can see how cellular is a tumor. There is mitosis. There was mitosis 3 per high power field, 10 high power field, and this is vascular proliferation in the tumor. And this is the necrotic areas. Most of the tumor is necrotic. This is mitotic figure. I put arrow on it. And this is the vascular endothelial proliferation. I put an arrow. Typical vascular endothelial proliferation. Cells look like a glomerulus. That's why it's called glomeruloid proliferation of blood vessels. And you can see how cellular is the tumor. Hyperchromatic. The tumor cells are not evenly distributed. This is usual in gliomas. We did immunostaining. Epithelial membrane antigen is negative in these tumors. We did it because to exclude many things. Part of it is not to be meningioma, atypical or high-grade meningioma, not to be metastatic carcinoma. GFEB is positive. You can see the brown is the positive staining. And all these spindle things are positive staining in GFEB. This is typical in glioma. IDH1 is very important to do IDH1 in all glioma tumors. IDH1 negative tumors, they usually do worse than IDH1 positive tumors. IDH1 negative, as in this case, usually they are primary glioblastoma, and they do worse than secondary glioblastoma. Secondary glioblastoma usually, like in grade 2 and grade 3, that transform into grade 4. This is what we call secondary glioblastoma. Usually IDH1 positive in adults, not in underversed in children. And they are, when they are positive, and you know that they do better than in negative. And usually when they are positive, IDH1 usually, not always, negative IDH1 will be 53 will be negative because they are the same pathway. And when they are positive, they are B53 will be positive. Ki67 was very high. You can see all these black or dark brown spots are Ki67, and you can see how much they are estimated 27%, and this is very high for glioma. This is glioblastoma multiforme, a high grade. B53 was negative because IDH1 was negative. You expected you go inside with glioblastoma or astrocytomas. So this is a glioblastoma multiforme WHA grade 4.
مرحبا دكتور عزمي الحديدي. We're talking about the butterfly gliomas. So just to go back to the Ki67, up to 4% is normal tumor, benign tumor. From 4 to 10 is medium, above 10, usually malignant. So you woke up on the table, they should not leave without being awake, fully awake. And this is the post-op. We have done a good job. We have removed good amount. Then we can send them for radiotherapy and chemotherapy. Other than this is a crime, and we have to fight crime.
Did you do the left side?
No, because it's mainly on the right side. So I went this way. You can see I've reached to this point. If it is the same thing on both sides, like we will see in the next case, then I'll go both sides. I published a paper some time ago, and I call it, do we need a neurosurgical Interpol? And we really do, to capture those mediocre surgeons. You can see that we have removed a good deal of the tumor. So it is not just somebody who's saying anything. It is based evidence medicine. Because why I do this? I do this the following morning. Why I do this? It's for me. It's for the patient, for the family, and for the residents to teach them the right thing. And this is the patient doing very well. No abulia, no anything. We have given him the good chance. Whether he would live for a year or 3 years, it's up to God, not to me. But I have done my job. So he was sent for radio and chemotherapy. And this is his discharge summary, which is a detailed one. Otherwise, it is not a discharge summary. Everything that should be written there. Second case is 42-year-old male Jordanian patient who lives in Canada, and he opted to come to Jordan. He's married to, he's Jordanian but living in Canada with a Canadian passport, married to a lady from Jordan. And just before presenting, his wife was pregnant and she gave birth just before surgery. That's him. Again, headaches, wobbly legs, imbalance. And this is the tumor, a bilateral, okay? So both sides are affected. But you can see that this side is affected more than because of the contrast enhancing more on the left than on more on the left than. What a biopsy would do in this case? Nothing. Having said that, a neurosurgeon in Amman volunteered and did the whole and took a biopsy and took a good amount of money. It cost him about 30 minutes. He went out, no complications, patient is awake because he has done nothing. And the histology was isocytoma grade 3, go for radiotherapy with confidence. Mediocre surgeons, they have confidence. Tumor is there. We did consultations, again, Dr. Maurice Sina, because of possibility of epilepsy in these patients. And we did very much important topic, which is the psychiatric consultation. We did not do it for the first patient because his wife is a doctor, she refused. Iraqi mentality means that if we ask for the psychiatry, then the husband is mad. This patient, because he was raised in Canada, he accepted it with his wife. So Dr. Melissa handled full psychological, which is done before and after surgery. And I keep repeating that we are one among very few centers around the world before surgery. Dr. Faras Sinem and surgery. This is our consent form, and I wrote it in English because he does not read Arabic. So I put it in English, and it was easy for me because I've just copied the form that we used in London back in the 80s. I have been told, and I understand it's a statement. لقد تم إخباري وفهمته. It's very important, these kind of statements. And the assessment, what is the aim, etc., etc. We have to be very careful. So again, we use the navigation, the same machine. I said Ziad Salah, very good machine. And again, I started with the left side because it is the more contrast enhancing. Again, with the use of this is the cross, so I know where I am. I am just below the Corpus Callosum. Cingulate Gyrus is there, so I'm avoiding Cingulate Gyrus. So you keep pointing these, you know exactly where you are. So we started on the left side. As this is still picture, I don't want to show more videos, but this is the left side. And then we went to the right side. And again, concentrated on the...
Temporal lobe.
Sorry?
What's temporal lobe?
No, it's completely in the frontal. Here you are in the within the corpus callosum. So it's not the temple. So went to the other side and did it. So this is midline. We opened the left side and the right side. We don't want to repeat the histology. It's the same thing like the one before. GFAP, IDH1, KI67, 6%. It is less than the previous patient. P53, sign up to Tyson. And again, it is JBM. What's the difference? We have done a good job for the patient. Also, he woke up on table, 15 over 15, no problem. And this is the evidence of how much we removed of the tumor without causing any damage. This is his discharge summary. Again, we sent him for chemo radiotherapy with the confidence that we have given him the best chance possible. This is immediate post-op. And this is when he came for the clinic for follow-up. Okay, I finished. If any questions, thank you very much.
Hello, Dr. Abraham. Can you hear me okay? Can you hear me okay, Dr. Abraham?
Okay. I don't know.
I want to try to get through, Mike. Are you there, Mike?
Yeah, I'm here.
Okay, let me try to get a hold of Dr. Abraham. Hello.
Now, atypical infections.
Yeah, hold on. Let me text.
They are taking the
Hang in there. Let me try
butterfly
get through him through
So
WhatsApp.
very
Yeah, normally, Mike, this is not an interactive session, but maybe I can get a hold of him. Okay.
It's fine. If you can, that's great.
Yeah, I'll try it because this tech is great, man.
Part of the world,
Really.
people know just 2 words about anything. Cellular region is pituitary.
Okay.
Both ventricular tumor is.
Hello, Dr. Abraham.
No, the differential diagnosis is very wide. And Dr. Hadidi added 2 things which are important, especially in our immunocompromised era. There are lots of AIDS, lots of immunocompromisation, and people
Total
with
technician.
coma or with toxoplasmosis. So when,
Hello, Dr. Abraham. Can you hear me?
I can tell you that we are seeing these cases, but people don't think about it because doctors in this part of the world, they live on a very small amount of knowledge, and they just practice on a very small amount of knowledge. They don't teach themselves. Nobody teaches them. So if he's graduated as such, he will remain as such for the rest of his life. Any other questions? I may assign.
Whoop. Whoop, whoop, whoop.
Very hard. Should not be left to practice their crimes on human beings. Lots of malpractice. Nobody is raising a finger. I will continue to raise my finger and raise my foot in the face of these people until the day I die. Thank you very much.
Hello, Dr. Abraham. Whoop. Dr. Abraham, I think he's coming back here. Hold on there.
Hello?
Yeah, hi, Dr. Abraham. Can you hear me okay?
Yes, I can.
Oh, excellent. This is a big day. We have a neurosurgeon from Oklahoma and Australia on the cutting edge of glioma research, Mike Segru.
Yes.
He would like to talk to you. I think you may have quoted one of his papers.
Yes,
Go ahead, Mike.
Yeah.
Hey, so I got up in the middle of the night because it's 1 a.m. here. I was so excited to see someone talking about this.
Thank you very much indeed. Your paper is excellent, and I thought I should refer to it.
Yes, we've updated our model a little bit. We've been doing a lot of work with connectomics. I don't know if I can. John, can I screen share and they can see?
Yeah, sure. Go ahead. Go ahead, Mike. It's all yours. And this is all being okay. This is all being televised and recorded.
Can you guys see this?
Yes.
Yes.
I can. Yeah.
So we published a series of papers in operative neurosurgery last year, and we basically made maps of the brain that look like this, more or less.
Beautiful.
Of everything. Yes. It ended up being an 18-part supplement, and this is where all this comes from. So.
Right.
We published it's almost 500 pages long, so I'm sure not everyone's read this.
Right. I will look it up and follow it.
So in there, what we came up with, we started updating the model, and this tract I think is very, very important, called the frontal aslant tract.
Yes. Yes.
This is the paper that we just submitted to JNS, and what we showed is that if you stay out of the frontal aslant tract, you eliminate the SMA syndrome.
Yes.
And we've known that for a while, but this is the evidence for it. So what we came up with, we started mapping the DMN into level of detail.
Yeah.
And there are two other networks that are involved in this, one of which is this network called the Salience Network and the Executive Network. And as you know from the paper, they look sort of like this. This is the default in green.
Yes.
There's the Salience in red,
Yeah.
and it shares part of the SMA right here. So they form like an axis. So we think that as long as you stay out of this axis, then you don't get abulia. This is an axis to get out of DMN and into action. So we've kind of come up with this system. What's interesting is you've shown what we've shown too, is that bifrontal, we used to think was both frontal lobes, but really it's both this.
Yep. Yep.
So that what you've shown that you can go through both frontal lobes. That's not the issue. It's the DMN and this system that you have to preserve.
Absolutely right. Absolutely right.
It's also great to see someone who hates biopsying gliomas more than I do. That's true.
I just think that this is my duty in life, is to show these mediocre surgeons what they are doing, especially in our part of the world, third world country, that you can easily mislead the patients by saying this is safer for you, we'll just do biopsy without complications. It is not safe. You are just putting the patient into danger by not treating him well. So this is a mission of my life.
It's not just your part of the world, it's everywhere.
Thank you very much indeed. Thank you for calling and thank you for the information. I will look it up, the paper that you mentioned.
Yeah, absolutely. I just thought I was going through Facebook and I saw those slides and I said, I'm going to go see what he's saying. Good to see someone's actually read my work and doing something with it.
Oh, it's brilliant work. Thank you for calling.
Well, you know, Michael, Dr. Abraham has been doing these multidisciplinary lectures for 25 years. And now we can televise them from Jordan. And we welcome you, Michael, to use this technology to connect research centers or whatever you want to use it for. We're going to hopefully work with Dr. Abraham to connect the Arab neurosurgical world. So thank you both for coming. Thanks for a great presentation, Dr. Abraham.
Thank you very much indeed. Thank you.
Okay. Thank you.
Bye-bye. Bye-bye.